Onc Live Insights is a video editorial program produced by Onc Live.
With imatinib, we have European data and American data that shows that the response rate to both 400 milligrams and 800 milligrams of imatinib upfront offers a response rate of about 50%, which is impressive for a disease that really had probably a 5% response rate with chemotherapy in the advanced setting. So as such, 400 milligrams is better tolerated for patients, and that's generally the first line approach. Even with a 50% response rate, the disease control rate is probably closer to 80% in these patients. So patients are maintained on therapy as long as they're responding and as long as they're tolerating it. We don't take breaks from therapy. There have been some studies that have looked at stop and go imatinib, and what we see in those patients is actually a much worse outcome if we stop the imatinib and then reinstitute it after some time. There seems to be a tumor flare type effect, and the patients do worse. So patients are continued on imatinib as long as they're responding and as long as they're tolerating it. It's important to have appropriate radiologic assessment, looking at these patients. Sometimes on the initial scans, the tumors after treatment can look bigger, but they're more homogeneous, so the tumor density changes, and that's important to be able to assess so that you're not stopping therapy too early or changing therapy due to lack of response if you're not looking at the proper radiologic criteria. So it's important that you're assessing patients appropriately who are getting therapy. Once you've established that patients actually do have progressive disease on imatinib, the first steps usually are to increase the dose of imatinib from 400 to 800 milligrams. In doing so, about 1 in 3 patients may benefit and achieve some disease stability after the dose increase. This can also be guided a little bit by the mutational analysis. For example, if you have an exon 9 mutation on 400 milligrams, they're probably going to be more likely to respond to an 800 milligram dose, so that could help guide you as opposed to just switching to sunitinib up front. But if you have established that the patient either can't tolerate the 800 milligram dose or has progressed on 800 milligrams, then the next step is usually to move to sunitinib or Sutent, which is VEGF, PDGF pathway inhibitor, and also is an oral agent that has been assessed in the second-line setting and is the standard second-line agent that's used. Once patients have progressed on sunitinib, we now have regorafenib, or Stivarga, which is a promiscuous tyrosine kinase inhibitor, which has now demonstrated activity in the third-line setting. So now we actually have agents to go to after imatinib, which we hadn't had for some time, particularly now in the third-line setting, as the regorafenib data is fairly new.
In a more recent Phase 3 trial evaluating regorafenib to best supportive care, patients receiving regorafenib had a longer progression-free survival compared to patients receiving best supportive care. The study resulted in another FDA indication in the third-line setting. While having 3 lines that are FDA approved is excellent and certainly a huge advance compared to where we were at even a decade ago, the problem that we still face is that some patients may still develop secondary resistance to all 3 of these medications, and then we have to think about what the next steps are. And though this is a disease that is commonly treated now by local or community oncologists, if a patient has failed 3 lines of therapy, they really should be evaluated at a high-volume sarcoma center or a center that sees GIST on a regular routine basis. And the reason for this is because most of these centers will typically offer clinical trials that can hopefully improve the outcome for these patients. What's interesting about the situation, though, is that there are a number of other tyrosine kinase receptor inhibitors, such as dasatinib, nilotinib, sorafenib, pazopanib, axitinib, and others that have been developed for purposes of treatment in other disease categories. But because many of these drugs are FDA approved, there are patients that sometimes may receive these medications in an off-label situation. The decision to use off-label use of these medications is a decision that definitely needs to be discussed between the treating oncologist and the patient to determine if this is a safe and reasonable expectation to perform.